Hello, everyone. Today, Rehab Podcast Weekly presents Episode 4 about clinical reasoning and goal setting.
Ever feel like understanding a health issue is like trying to, I don't know, decipher a foreign language?
Definitely.
You want to know how to get better, right?
Yeah,
But the medical world, it can seem so complex.
you really can.
Today, we're going to try and demystify some of the key processes healthcare professionals use to make sense of it all and, chart a course for recovery.
Exactly. We're taking a deep dive into clinical reasoning, basically.
Yeah.
How they figure out what's going on,
Yeah.
and goal setting and rehabilitation. So how they plan the way forward. We've looked into discussions among healthcare pros and the research behind these essential skills.
Yeah, and our goal here is really to make these ideas clear and hopefully useful for you. Whether you're in healthcare yourself, maybe navigating your own recovery, or even if you're just curious about how medical experts approach patient care.
Mm-hmm.
Okay, so let's unpack this. Where do we start?
Let's start with clinical reasoning. Think of it as, well, the detective work of healthcare.
Okay, detective work. I like that.
Yeah. It's a really detailed, patient-focused way of collecting information and then using it to understand what's happening with someone's health. This whole journey, it goes from identifying the problem, the diagnosis,
Right.
to figuring out solutions through goals and plans, and then crucially, seeing how well those plans actually worked out.
So it's much more than just slapping a label on it, naming the illness.
Yeah,
It's a whole investigative process.
absolutely.
And that first part, getting to a diagnosis, that feels like, well, the most critical step, doesn't it?
It is pretty fundamental, yeah. So when someone has a health concern, they'll often, go see a doctor or a therapist.
Mm.
The professional then starts the diagnostic process. And they use diagnostic criteria and guidelines. These are super important because they help pinpoint specific conditions and, just as importantly, tell them apart from others that might look similar.
Okay. We had a good example of this, I remember, comparing gout and rheumatoid arthritis. Could you walk us through that again, just briefly?
Sure. So finding urate crystals, like little needles, in fluid from a joint, that's a very strong sign of gout. Pretty clear-cut, usually.
Okay.
But diagnosing something like rheumatoid arthritis, well, that's often more involved. It usually requires meeting a combination of criteria, looking at the person's symptoms, what the physical exam shows, lab results.
Right.
It's rarely just one single thing. It's about the whole picture.
That makes sense. It really is like putting together pieces of a puzzle. So once they have all this information, how do they actually describe what's going on? What kind of language are they aiming for?
Yeah, the goal is always clarity and objectivity. Our source really emphasized avoiding vague language. You want to describe the patient's issues precisely without jumping to a conclusion, a diagnosis, too quickly.
Okay. So less room for guesswork, more focus on concrete observations.
Got it. And you mentioned a memory tool, Invited MD. That sounds intriguing.
It is. It's a useful way, really, for healthcare professionals to systematically think through different categories of potential causes.
Okay, break it down for us. Invited MD. Right. So I is for infection, N for neoplasia. That's like new tissue growth, maybe a tumor, V for vascular blood vessel issues.
Okay.
I is inflammatory or autoimmune. T is trauma. E is endocrine hormone problems. D is degenerative conditions. M is metabolic disorders. And the final D is drugs, medications causing issues.
Wow.
It's basically a mental checklist. Helps ensure you consider a broad range of possibilities.
That's a fantastic framework. Seriously.
Yeah.
Like having a structured way to brainstorm possibilities. Now, how do they decide, how much digging is enough? You can't just order every test under the sun.
Right. That's a really, really important question. How much diagnosis is enough? Often, an initial impression, sort of a working hypothesis, comes from just listening to the patient's story and doing a physical exam.
Right.
This might point towards a syndrome. Think of a syndrome as just a collection of signs and symptoms that often appear together, like, say, acute coronary syndrome.
Yeah.
Then further tests, maybe simple ones, maybe more complex, might be used to get a more precise diagnosis or figure out how severe it is, or even see how well treatment is working.
So it's often a process then of gradually refining the picture.
Yeah.
But what happens when it's murky? When the situation isn't clear right away?
Yeah, that happens. And that's where watchful waiting can actually be a really valuable approach.
Watchful waiting.
Yeah. See, many conditions have a natural progression. Some get better on their own, some stay the same, others evolve over time. So sometimes it's genuinely best to just observe how things unfold before locking in a diagnosis. Our source even mentioned that some conditions have diagnostic criteria that are based on time, like someone might have an initial episode of symptoms suggesting, say, myelin damage, that's the protective covering on nerves.
Right.
It might be called a clinically isolated syndrome initially. A full diagnosis of multiple sclerosis might not happen until or unless further episodes occur at different times.
Ah, I see. So it's like an early warning sign, and you need to see if it repeats.
Kind of, yeah. Doctors need to see if more events happen over time to be sure.
That's fascinating. So sometimes just waiting and seeing is the best course of action. And I guess that also helps avoid rushing into expensive or maybe even risky tests unnecessarily.
Exactly that. It's always a balance, you know. Balancing the need for answers now with the potential downsides of testing, especially if the clinical picture isn't totally clear yet. Observing how things unfold can sometimes give you the crucial info you need to pick the right tests, if any are needed at all.
This whole process sounds incredibly intricate, really complex thinking. I know our research touched on different models, attempts to explain how doctors actually do this thinking, these clinical reasoning models. Can you give us a quick rundown of some of the main ones?
Sure. Yeah, researchers have been trying to understand this for a while. One of the earliest and still influential is the hypothetico-deductive model.
Okay.
This basically suggests that clinicians, even experienced ones, quickly generate a few possible diagnoses hypotheses quite early on. And then they gather more information specifically to either support or rule out those initial ideas. So for you, if you're facing a health issue, just remember those initial theories might change as more info comes in.
So it's like making a short list of suspects and then looking for evidence for or against each one.
Precisely, yeah. But, like any model, it's not a perfect description for every single situation.
Right. What are the criticisms?
Well, some argue that real-world clinical reasoning isn't always so neat and step-by-step, and we don't fully grasp all the sort of underlying psychological mechanisms. There's also debate about whether it truly captures the difference between how experts and novices think.
But it's still useful.
Oh, definitely. Proponents argue it provides a helpful structure, especially for complex problems, and it can be a great learning tool for students, you know? Plus, it can be really useful when the initial information is pretty vague or limited.
Okay. What about other ways of thinking? I remember reading about illness scripts and pattern recognition.
Right. So those models focus more on how we organize and retrieve knowledge. Illness script theory suggests we develop these mental summaries of diseases based on what typically causes them, the core problem itself, and the usual outcomes or consequences.
Like a mental file card for each disease.
Sort of, yeah. And pattern recognition is pretty much what it sounds like. Experienced clinicians often recognize familiar patterns of signs and symptoms they've seen many times before.
Ah.
This can lead to a more immediate, almost intuitive diagnosis. Think of a seasoned doctor who just knows what it is based on a few key clues.
So it's like a shortcut based on lots of experience.
In essence, yes, but it has limitations too, of course.
Such as?
Well, you might overlook unusual cases that don't fit the standard pattern, or complex cases with multiple things going on, and it tends to work best within very specific areas of expertise.
Right. And then there were models trying to combine these different approaches, the fast intuition and the slower thinking.
Exactly. Dual processing theory is a big one there. It suggests we use two main modes of thinking: a fast, intuitive system 1 and a slower, more deliberate, analytical system 2.
System 1 and System 2. Okay.
And related to that is the cognitive continuum theory. This basically says our reasoning exists on a spectrum, from purely intuitive at one end to highly analytical at the other, and we shift along that spectrum depending on the task and the situation. So yeah, your doctor might sometimes have a quick gut feeling, but for tricky stuff, they'll definitely engage that slower, more analytical gear.
It really sounds like the reality of clinical reasoning is, well, messy. It probably involves a mix of all these different strategies depending on the situation.
That's absolutely the key takeaway from the research. These models, they each give us a partial view of a really complex cognitive process. Some researchers even think we might eventually need a kind of unifying meta-model or meta-theory to really wrap our heads around it fully.
Okay, so that's clinical reasoning, how healthcare pros figure out what's wrong. Now let's pivot to what happens next. How they plan the path forward, especially in rehabilitation, with goal setting. Why is setting goals so crucial here?
Oh, goal setting. Yeah, it's absolute vital in rehab for, well, quite a few reasons, actually.
Okay.
It helps optimize how well a patient can function, number one. It's also a really strong motivator for many people. It helps make sure everyone on the rehab team, therapists, doctors, nurses, is pulling in the same direction.
Right on the same page.
Exactly. It can also shine a light on areas that might otherwise get missed. And of course, it gives you a way to track progress. But maybe most importantly, it empowers the patient. It integrates their own motivations, their own desires into their recovery journey.
So it's not just about the clinical stuff, what the providers think is important. It's about connecting it to what the patient actually wants to achieve in their life.
That's the ideal, yes.
Are there proven benefits then? Does the research back this up?
Yeah, the research generally indicates that using goal setting can improve a patient's health-related quality of life, and it can boost their confidence in their own ability to manage things, what we call self-efficacy.
Okay.
However, the evidence on whether it directly increases, say, motivation itself, or how much patients actually participate in activities, that's a bit more mixed, not always a straight line.
That's interesting. You'd kind of assume setting goals would automatically boost motivation across the board. Now, I've definitely heard of SMART goals. Is that the main framework people use?
SMART is very, very common, widely used, definitely. And just to remind everyone, it stands for specific, measurable, achievable, or attainable, relevant, and time-bound.
Right. Specific, measurable, achievable, relevant, time-bound.
The basic idea is that goals with these characteristics are more likely to be effective, more likely to be reached.
Makes perfect sense on paper. But is it always that straightforward to apply those SMART criteria in the real world? Especially in complex rehab situations, like with spinal cord injury, which we saw in one of our sources.
Ah, that's where it gets tricky. That's a significant challenge. The research we looked at, which specifically explored healthcare professionals' experiences with goal setting for spinal cord injury outpatients,
Yeah.
it really highlighted the difficulties trying to rigidly apply those ideal SMART criteria to the messy reality of patients with really complex, varied, and often unpredictable needs. It's tough.
What kind of difficulties were they running into?
Well, professionals often struggle to make goals truly measurable or
Mhm.
realistic or strictly time-bound when dealing with all the different challenges of SCI. Think about it. How do you precisely measure something like improving independence?
Hmm.
Or set a firm deadline for progress when recovery can be so variable and influenced by so many other factors,
Mhm.
social, environmental, psychological.
Right.
That ideal SMART goal sometimes just needs a dose of real-world flexibility. And for you listening, if your goals need adjusting along the way, don't get discouraged. That's actually a normal part of the process.
So they can't always stick rigidly to the letter of the SMART law, so to
Yep.
speak.
Pretty much. The study described what the researchers called a tinkering approach.
Tinkering.
Yeah. It means the professionals adapt the concepts, measurability, realism, timeframes to fit the specific context, the individual patient's situation, while still using their clinical judgment, their expertise.
Okay.
It's not about throwing the criteria out the window, but about thoughtfully adjusting them to make them more practical and meaningful in that specific case.
That sounds like a really pragmatic way to bridge that gap between the textbook ideal and the clinical reality.
Right.
It also brings us back to that idea of person-centered rehabilitation.
Yeah.
How does goal setting fit with really focusing on the individual?
Ideally, it fits perfectly. Person-centered rehab emphasizes that goals must align with the patient's life, their values, what they want to achieve. It's about going beyond just fixing the impairment or the disease itself.
But I sense a but coming.
Well, haha, yeah. Truly putting this into practice can be difficult. You can have different perspectives, right?
Yeah.
Different priorities, different agendas sometimes between the professionals and the patients.
Can you give us some examples? Where might those differences show up?
Sure, sometimes patients find it genuinely hard to define goals in a way that's easily measurable, the way a therapist might need. Or, conversely, professionals might feel like they end up having to sort of formulate the goals for the patients because the patient is struggling to articulate them.
Right.
And patients often focus on big picture overall life improvements, which is totally understandable, rather than the specific measurable objectives that fit neatly into a structured rehab plan. One source mentioned a patient whose initial goal was just to get back to normal.
Yeah, I can see how that's meaningful for the patient, but maybe not very actionable for the therapist.
Exactly. It's understandable, but not very specific or measurable for guiding the actual therapy sessions day to day.
So how can do better? How can they better weave what truly matters to the patient into this goal-setting process?
Well, one promising idea that came up is thinking about a hierarchy of goals.
A hierarchy,
I-
like different levels.
Kind of, yeah. You start at the top by really exploring the patient's overall hopes, their aspirations for their future. What does a good life look like for them?
Okay.
Then, based on those broader beliefs and wishes, you work together to develop meaningful, maybe slightly broader, overarching rehabilitation goals.
Right.
And then finally, you break those down into the specific actionable steps, the more SMART-like goals, perhaps that guide the daily work. This approach could be a much better way to connect the patient's big life goals with the immediate objectives of rehab.
That sounds much more holistic. Were there any other frameworks mentioned besides SMART? You mentioned JAS.
Right, primarily SMART, but goal attainment scaling, or GS, also came up. GS is basically a method where you define different levels of expected outcome for each specific goal, usually on like a 5-point scale ranging from much less than expected to much more than expected.
Oh, okay.
It can be really useful for tracking progress towards more individualized goals, where a simple yes-no for achievement doesn't quite capture the nuance. And one source did note that GAS has been shown to be a valid way to measure outcomes in certain rehab settings.
Interesting. So, okay, you've collaborated, you've set these goals, maybe using SMART or GAS or this hierarchy idea. What's the absolutely crucial next step to actually make them happen?
Implementation plans. You need clear implementation plans.
Okay.
Meaning you need to clearly define who is going to do what, when they're going to do it, where, and how. Having a really well-defined plan, make sure everyone involved, crucially, including the patient consent, understands their role and what needs to happen to work towards those goals.
Right. No point having goals if nobody knows how you're supposed to reach them.
Precisely.
And I guess it's not just set and forget, is it? You have to keep checking in.
Absolutely not set and forget. Regular evaluation and feedback are vital. You need to monitor how well the goal-setting strategies are actually being put into practice and what impact they're having. Are things moving in the right direction?
So you can see if the goals are actually being met, or if maybe the goals themselves or the plan need tweaking.
Exactly. It allows for adjustments along the way.
Okay, so let's try and tie this all together now. How do these two big concepts, clinical reasoning, the understanding part, and goal setting, the planning part, how do they actually work together in the day-to-day practice of rehabilitation?
Well, they're intrinsically linked. Clinical reasoning provides that essential foundation, the understanding of the patient's situation, identifying their key problems, but also their strengths and resources.
Yep.
That understanding then directly informs how you develop relevant and appropriate goals with the patient within the specific context of their rehab. Basically, the diagnosis and the deeper understanding of the problem directly shape what you're aiming to achieve with the goals.
And how does monitoring progress fit into that loop?
Monitoring progress links back to both pieces. It links back to the initial clinical reasoning, asking, was our understanding of the underlying issues actually accurate?
Right. Did we get the problem right?
Yeah. And it links to the goals. Are we making the progress we expected towards what we set out to achieve? Those regular review meetings people have in rehab, they're often used specifically to assess progress toward goals and then plan the next steps.
Makes sense.
And in that spinal cord injury outpatient setting we looked at, they often had a typical time frame, like maybe 3 months for a block of rehab. That time frame helps structure the goal setting and the review process, although, again, those timelines absolutely need to be flexible based on the individual.
So it really is a continuous cycle then.
Yeah.
Understanding the problem, planning the approach, taking action, seeing what happens, reevaluating the understanding, adjusting the plan.
Precisely. It's a dynamic loop.
Well, this has been a really, really insightful deep dive.
Yeah.
Covered a lot of ground on clinical reasoning and goal setting. To sort of bring things towards a close, what are some of the key messages you'd want our listeners to really take away from this?
Key messages. I think the most important things to remember are that clinical reasoning is that fundamental process for understanding the health issue in the first place.
Right.
And goal setting provides a structured, collaborative pathway towards recovery or better function. However, and this is a big however, both are really complex, deeply patient-centered processes. They require flexibility, thoughtful adaptation, and a genuine focus on the individual's unique situation, their needs, and their aspirations.
And for you personally, looking through this material, what were some of the most interesting, maybe aha moments?
Good question. I found the discussion of all the different clinical reasoning models pretty fascinating, just seeing how each one offers a slightly different angle on this incredibly complex way of thinking. Also, really getting into the practical realities behind that tinkering approach to SMART goals. It really highlighted the skill and the adaptations involved for clinicians on the ground.
Yeah.
Finally, just reflecting on the ongoing challenge of achieving truly person-centered care. Even with the best intentions, bridging that gap between the system and the individual is still something we're working on. That really stood out.
And for our listeners tuning in, what kinds of questions might they be mulling over now after hearing all this?
Well, you might be thinking about how these processes connect with your own experiences, maybe with healthcare you've received or observed.
Yeah.
You might be considering how medical professionals approach care now with a bit more insight, and maybe thinking about the balance between needing structured, measurable goals on one hand and respecting individual needs, preferences, and maybe more holistic life goals on the other.
Yeah, the tension is really interesting. And what's the final thought you'd like to leave everyone with today? Something to maybe chew on.
Okay, here's the thought. If healthcare at its core is really about improving people's lives, not just treating diseases,
Hmm.
how can we continue to get better at bridging that gap? The gap between our standardized medical frameworks, our systems, our SMART goals, and the incredibly unique personal lived experience of each individual who comes seeking care.
Hmm.
It's worth thinking more about how patients can be even more actively involved in shaping their own care plans, and maybe keep an eye on the ongoing research that's trying to refine both clinical reasoning and goal setting in ways that truly, genuinely put the person right at the center of it all.
Edited by Min. Rehab. Thank you all for listening, and see you in the next podcast.